Don't worry about the intro slide. You will be listening to Dr. Ackerley this evening talking about mold and biotoxins. I'm going to start with a little introduction about Psychiatry Redefined. People are still coming in the room, so wait another minute and then we'll get started. So I started Psychiatry Redefined about 5 years ago as a kind of educational platform because I was getting both frustrated, angry, and very confused as more and more people were leaving traditional psychiatry and just trying to do something different. And it got very confusing as everybody had a different name and everybody had a different approach, and everybody's approach was the right approach. And the functional people didn't talk to the integrative, and the integrative didn't talk to the restorative and the anti-aging. It just got both a little silly and a little ridiculous because the patients really weren't the center of the conversation. And I was kind of focusing on trying to take this information overload. And here I have traditional journals, but it's certainly our research now that has placed the work that Dr. Ackerley's been doing for many years, that I've been doing, into kind of a research evidence-based programs has just made our jobs much easier. And I think education and training now can be based on science. And that was kind of the goal for Psychiatry Redefined, is to sort through the information, the overload, with kind of clinical skills and experience. And I think anyone in the mental health field certainly can appreciate that our prescription practices are random, sometimes dangerous, and polypharmacy is the norm. And I do a lot of training of residents, and I can ask 5 residents the same case and they'll all have their different drugs because their supervisor told them that this is the better drug. It's not based on science or research. It's based on either the best drug rep or the best supervisor who recommended it. So psychiatry is gone from multiple educational kind of platforms to this kind of symptomatic based polypharmacy, right? All we do is measure symptoms based on his 1,000-page DSM. We give a treatment with a drug, and then we kind of measure symptoms again. Depression is not a Prozac deficiency. And we spend our time training psychiatrists how to prescribe meds. One of the things I've been certainly interested in is medication withdrawal, and try to teach physicians how to taper and stop medications. And this, I guess, is where I wanted to get to, is too much of what I call kind of integrative medicine, used to be called complementary and alternative medicine, has really seeped into academic medical training. It's nice that there's mindfulness programs at Harvard and Stanford and Arizona and most academic centers, and diet and lifestyle are now subspecialties. And I think it's very incredibly helpful. But what has kind of been missing, which I think has been critical to me and the basis of the Psychiatry Redefined, is really the functional medicine approach, is looking at individuals, genetic vulnerability, environmental insults, whether it's mold or toxins, and then seeing what the body is doing and what it needs. And that's based on a lot of testing and a lot of clinical skills. And Psychiatry Redefined is really based on this functional medicine model. It's not excluding mindfulness and yoga. We have some yoga courses coming up, but the core of our program is functional psychiatry or functional medicine for mental illness. Every patient is different, regardless of the etiology or genetics. So the brief version, what we're doing. We have courses, we have fellowships, we have books, we have webinars at least once a month, which you get the fortune of hearing Dr. Ackley, and we have many courses. The fellowship, I believe that there's so much information. We started it as a one-year program. Now it's 2 years because just so much content. So it's 2 years, 70+ hours of content, group community, supervision groups twice a month, where people present cases and ask questions, and then private mentoring sessions for those new. And then this year we've been quarterly putting on conferences so we can keep up-to-date information. And this is a core curriculum where each of these topics are not described and looked at as medication deficiency syndromes. They're kind of looked at as in a functional model, looking at underlying biochemistry that might be contributing, genetic vulnerabilities, and treatment protocols, and a lot of testing, understanding what's going on. So we cover all major, and then we have additional courses. Dr. Shaw talks on mycotoxins, tidal bombs, SHINE protocol, adaptogens, and we have new courses all the time. So we did this functional medicine approach, and we're looking for the concept of understanding mental illness, regardless of the diagnosis, as a reflection of errors in physiology, that genetic environmental kind of mismatch at that moment in time, and trying to understand those causes. We can begin to use words like cure, remission, and people get better with a functional psychiatry approach. These are the first symposiums that we have. The recordings are available. We did food addiction and binge eating. And then my favorite from speakers from around the globe on low-dose lithium, traumatic brain injury, suicide, cancer, dementia. And then the next one coming up, July 17th, is genetic testing. We've all sort of been overwhelmed with the hype from companies marketing either supplements or drugs. And so we have an expert lineup of people providing some really expert case studies and benefits. So that's on the 17th. So let's get to the punchline tonight. I'm glad that everyone's with us. We try to do a couple webinars a month. And this month we're fortunate to have Dr. Mary Ackerley. Dr. Ackley is a physician, classically trained, board certified psychiatrist and integrated physician. She graduated summa cum laude from Harvard, studied at NIMH, and did a residency at Johns Hopkins. Dr. Ackley began to treat biotoxin patients in 2010, certified to treat chronic inflammatory response syndrome in 2013. Like any great clinician, she doesn't work with any confines of one protocol, but continues to build on a foundational knowledge by expanding fields of neuroimmunology and systems biology. Patients seek out Dr. Ackley for anxiety, depression, chronic fatigue, brain fog, special skills as a clinician, psychiatrist to manage cognitive and psychiatric symptoms that often occur in these complex environmental illnesses. And fortunate to have Dr. Ackley share her expertise and knowledge with us tonight. So welcome, Dr. Ackley.
Hi, that's a wonderful introduction. Thank you very much. I enjoyed listening to it. So my name's Mary Ackerley, and I call myself an integrative functional psychiatrist. I think we just took the word holistic off the SEO on my website so that listening to you talk about the words and defining ourselves as psychiatrists and what we do is an ongoing issue in distinguishing what we do and distinguishing ourselves from others who do something similar but are not psychiatrists. And I believe being a psychiatrist is pretty important. We have some very special training. So I'm very delighted to be able to talk to a group of psychiatrists tonight about my interest, why I became interested. So I've been working with mold patients here in Arizona, Tucson, Arizona, for more than 10 years. And I know that seems a little strange to people when they first hear it, but it turns out Arizona is actually 6th in the country in mold claims. And one time it was 4th. So that's a lot of mold. Of course, our joke is it's a dry mold, the same way it's a dry heat, but it's true. We have a lot of mold, and it's perhaps even more toxic than that found in humid climates. And I became interested in mold when I started seeing patients from Dr. Michael Gray, who's been treating mold patients. He's a toxicologist, MD. He's been treating them since the 90s, an incredibly smart guy. He's practicing in Benson, Arizona, which is kind of in the middle of nowhere. And his patients started finding me because they knew I practiced some form of psychiatry, integrative, and that I didn't really want to use medicines and I preferred diet. And they were hoping I could help them with their mood and anxiety and some hormonal changes while they were undergoing mold treatment. So like any good psychiatrist, when I first started seeing mold patients, I just decided they were psychosomatic, right? Who ever heard of mold? And these people had all sorts of symptoms that were not explainable to me in any sort of traditional neurological understanding. And I didn't say much because I was a polite person and I knew that it wasn't a great way to keep patients to just call them psychosomatic. And I would treat what they asked for. But at some point, I noticed that, they came with all these labs and they were pretty meaningful. They seemed to change over time. I had no idea what any of these cytokines were: transforming growth factor, metallomatrix proteinase, MMP9. And I became somewhat intrigued because while I was treating them for their mood, I was also noticing, hey, these symptoms, they have this joint pain, this frequent urination, this cognitive decline, they're all improving too. So I was intrigued, but it's hard to get to know how you're going to treat this, given this overwhelming amount of terms you've never heard and understandings of toxicity I wasn't particularly familiar with. So I've described my first mold patient before, but I was treating an older woman. She was about 70 then, who had been to my office multiple times. And one day she was just really late, and I called, and we had cell phones then. And I said, "Where are you, Deanna?" And she said, "I don't know. I'm lost." Now, she's a native Tucsonian. She had lived here 70 years. She'd been to my office multiple times. I had no idea how she was lost in familiar places. We guided her here. And when she got here, she was like bewildered and disheveled and tearful. And I asked, what's happened? Because last time I had seen her, she'd looked pretty good on, some of the supplements you've heard described, talking about some multi-nutrient supplements. I think we were using some organic lithium and fish oil. And she said, her home was being renovated, and she said, and they found mold. They found mold all over the ceiling, and they found it in all the walls. And I'm living here while they're doing it, and I've been feeling really bad. And now I have this explosive diarrhea, and I think she ran to the bathroom a few times and came back. And I just feel anxious. I'm not sleeping. I don't know what's going on, and I'm getting lost everywhere. And I'm talking to her, and I think she knew her name. I wasn't sure she knew the date. Her mini mental status was not very good. And I'm thinking, maybe I'm going to have to call her sons, for assisted living. I don't know what's going on. But she gave me the clue of mold, and I knew I was treating mold patients. So together we read the book, Surviving Mold. We just read it, at the table, at a kitchen table, and said, here are all the symptoms of mold. And she said, oh, I have this one, this one, this one. Plus I have that, ice pick pain. My God. And I really remember that. What is an ice pick pain? Headache. But she had it. So I read, the treatment is cholestyramine. Everyone I was seeing was on this concoction of, cholestyramine, clay, and charcoal. They called it mold shakes. And I said, look, I can start cholestyramine. That seems pretty benign. I knew it was used to stop diarrhea. She had diarrhea. So she insisted on driving home. We got her a prescription of cholestyramine. And I didn't even really know the side effects, but luckily she had diarrhea. So it actually helped her diarrhea pretty fast. So 3 weeks later, she was a different person. She found her way. She drove right here. She knew her name, the date. She knew exactly what had happened. Her diarrhea had stopped. She was sleeping. And I said to myself, wow, this is impressive, because who has ever seen, something that looked almost like dementia, really could have been dementia with her mini mental status score, cure itself in 3 weeks taking cholestyramine. So this made a big impression on me because I like to see people get better. I got very intrigued, and I pretty rapidly started to find I had other mold patients in my practice. In fact, when I just started asking some of my patients with multiple symptoms that didn't seem to get better, and we'll go over some of those symptoms, do you think you might have mold? And some of my patients I still have now remembered me saying that. Do you think you might have mold? They started looking and they found they had mold in their ceilings and their walls. It turns out that's really common in Arizona, where we have flat roofs that leak in the monsoons every year. And the traditional wisdom is that it'll dry out. It's dry heat, dry mold, it'll dry out. Well, it doesn't dry out. It goes dormant, and every time it rains again, the mold spores grow and spread, and it goes exactly like that through the roof, down the walls, and nobody knows because it doesn't smell without humidity. So turned out to be pretty common. It's clear I had a whole lot of patients with major mold exposure. And I'd been treating them just for depression and anxiety that was not getting better traditionally. So you might be thinking already now, as a psychiatrist, well, I certainly have some patients like this too, because they end up in integrative functional psychiatrist's office looking for better treatment because the SSRIs have made them worse. And so I, went on, I learned a lot. I became certified by Schumacher as the second person certified. I've learned a lot of technical details about it, about inflammation and immunology. And I started realizing, wow, I was getting a whole lot of people better faster by understanding mold and treating them. There's a doctor, yeah.
I just wanted to make sure, I don't know if you were starting without your slides.
No, you're seeing that. I'm going to be going to the slides. I was just.
Okay, perfect. Yeah, just make sure and hit share screen when you're ready.
Thank you. Okay, thanks. Okay, are we sharing now?
Perfect, thank you.
Thank you, Heather. Okay, so it's been said by some doctor that just about every doctor, probably every doctor in America is seeing some mold patients, and I agree. So a few years later, with this experience and certifications, after seeing multiple mold patients with major neuropsychiatric symptoms, I wrote Brains on Fire on the internet. I guess it went viral, and I still get people thanking me, calling up from around the world, thanking me for helping them understand the root cause behind their rage, depression, anxiety, suicidal depression, and setting them on the path to treatment. And in 2017, I've become so passionate about this, I've helped found ICI, the International Society for Environmentally Acquired Illness, to help promote the education, teaching, and research in environmental illness. The need is profound. So what I'm going to be doing today is giving you an hour introduction and hopefully igniting some of the passion that I still feel for understanding inflammation as one of the root causes of infection, of psychiatric illness. And I'm going to explore some of the current research and behind it, show you the levels of evidence for it. It's really well established by this point in 2021 that inflammation is a major cause of neuroinflammation. And with that, I'm going to go on. So here we are, starting with where we are in the depression. Dr. Greenblatt just gave you a very short summary of the same ideas. Depression's a really common illness. It's about 17% of the population is going to have an episode. Who predicted that in 2030 would be the major cause of disability in the world? I think with 2020, we may be seeing that earlier than 2030. And the research on antidepressants is pretty much that antidepressants, or at least SSRIs, are no better than placebo for mild or moderate depression, and maybe only 10% more effective for the severely depressed. And the clinical rule of thumb I know is SRIs get about 50% of patients about 50% better. And the problem is these facts, which are well known and passionately debated in the psychiatric community, doesn't discourage most clinicians and patients from using and wanting antidepressants. 250 million prescriptions were written, I think, in 2015. It's only increased every year. That's 1 in 10 patients getting a prescription for antidepressants. And what's amazing about that is that there's no generally accepted biomarker or clinical test for depression. So you're giving 1 in 10 patients in the US a prescription for something that we don't really have clinical biomarkers. So these are some of the conclusions I've come to in the last 10 years, is that there's more to the brain than neurotransmitters. And I'm going to explain that statement as we go on. And diagnosis is very oversimplified. And even the head of an NIMH, this is Insel, his brother is an endocrinologist here in Tucson, really good. He came out and stated a while ago that functional and structural brain imaging research has not been able to find consistent correlations with classical diagnoses. However many diagnoses we have, we really cannot just whip out an MRI and say, depression, you know, et cetera. So I think we can all agree there's some room for improvement. And today I'm going to go through the literature pretty fast to help everyone here who's a professional understand how many associations there are between water damage, the immune system, and hormonal dysregulation, the causes and effects of these dysregulation on neuropsychiatric function. So, as I said, psychiatric community is really pretty aware of the data I just presented, and there has been a number of papers written, and by 2021, there's a large number. And some of these titles are great: Inflamed Moods, Anti-Inflammatory Treatment of Depression, and my favorite, so depression's an inflammatory illness, but where does the inflammation come from? And I imagine that this has been talked about multiple times in this course. There are different causes of inflammation here. The slide presents many factors contributing to chronic non-resolving inflammation. We have numerous factors: there's obesity, diet, early life stress, psychosocial stress, permeable gut epithelium, T-cell dysregulation, pro-inflammatory Th17, and that this contributes to basically all the major chronic illnesses of our time. It's just basically a gateway to cardiovascular disease, diabetes, cancer, depression. And with this slide, I wrote in 2 causes that are not on the slide. I'm going to be talking about SIRS today, and I've also included EMF, which is something that there's actually a lot more evidence in the literature than has been commonly acknowledged in academic medicine. So SIRS, which is chronic inflammatory response syndrome, it is the name that many of us use for the cluster of symptoms we call mold, is often mistaken for a neuropsychiatric symptom, such as syndromes such as depression and anxiety. SIRS consists of many symptoms spread out through multiple organ systems, and the sheer complexity of these symptoms is just too much for our modern health system, which is going to overwhelm any high productivity medical practice, which needs to rotate people through every 15 minutes to meet their overhead. So that's why the treatment of SIRS is usually relegated now to specialist functional docs and is not seen again in most PCP offices, even though many start their journey with their PCP. The multitude of symptoms that are seen, and I'm not sure how many people in my audience have seen mold patients that they know what are mold patients, is going to be, again, multi-symptoms. So energy, most common complaint you see is complaints of fatigue, generalized weakness, or just post-exertional malaise, chronic fatigue. And the oftentimes patients who are complaining of that often get labeled lazy. The next we're going to see is a lot of respiratory symptoms, shortness of breath, asthmas. These symptoms are recognized by the medical community. Although most of the rest aren't, they can be associated clinically with mold. And in fact, I remember seeing a couple here a few years ago in which one couple, an elderly couple, had been exposed to black mold that had come through a leaking window. It was pretty extensive, the mold, before it was found. The husband had severe respiratory difficulties. He was hospitalized and treated appropriately, and mold was, accepted as causing the issue. His wife, who I was seeing, became severely depressed, received multiple ECT treatments, and it was being suggested that her symptoms were a reaction to losing the stability of her husband. I think that was the exact quote. And my efforts to say, well, I think the black mold was affecting her brain met on deaf ears. So the brain is very affected in mold for reasons we'll be talking about. Muscular pain is very widespread. It's often called fibromyalgia. The extremities can have poor perfusion, can look like multiple sclerosis. And in fact, that was my second mold patient, had been called MS. GI, very common, and it's very common also to people have the onset of explosive diarrhea, multiple GI symptoms, get colonoscopies, and no one ever thinks of the bathroom leak next to their master bedroom. The next set of symptoms here, and I said there are a lot, are ophthalmological. It's going to be just the blurred vision, sensitivity to light. Really, that's one of the things. If you start hearing that, you ask about sensitivity to light, sound, noises, smells, EMFs. They tend to all run together because of neuroinflammation. Again, pain, headaches, migraines, joints, dermatological rashes, hive sensitivity, cardiac POTS dysautonomia, extremely common in the patients I see, tachycardia, endocrine, frequent urination is extreme thirst, urination, temperature regulation, night sweats, impotence, and then weird stuff, sensitivity to static shock, non-anatomical, and this one's really important, numbness and tingling like the top of the head. There's this internal buzzing people can have that's very bothersome, and nobody knows what that is. Metallic taste and multiple chemical sensitivity. The most common symptom you're going to hear, it's not really a symptom, but history is been to see 10 or more doctors without any resolution of their symptoms, but with multiple diagnoses. And by that time, often suggested seeing a psychiatrist would be useful, because very few patients get through this journey to getting a diagnosis. At least it was for most of the last 10 years. I'd say the last couple of years, this is changing without hearing the suggestion that they'd be better off just seeing a psychiatrist than wasting everyone else's time. The neuropsych symptoms usually have at least one or two. Anxiety is by far the most common symptom I see in all of my patients, followed by insomnia. Again, very commonly seen in any psychiatric practice. Mood swings, depression, decreased resilience, the fatigue during the day, alert at night, cognitive impairment, often known as moldy brain, the short-term memory loss, word finding difficulties, poor concentration and focus, asking the same question repeatedly and forgetting the answer. Many patients who come to me think they have dementia. Fortunately, a few do, but most do not. The lack of motivation, difficulty planning and executing, incredibly easy irritability, anger, and loss of impulse control, also known as mold rage. And something I noticed early on and patients talked about was suicidal ideation. It's pretty common, just passive, waking up in the morning, sorry they had woken up. But there's another type, which they'd say is they were feeling pretty well, would go into a building and feel suicidal, walk out, and they would lose the suicidal impulses of thinking they needed to off themselves by just walking out. Now, it's another thing that no psychiatrist is going to have an explanation for. That doesn't happen unless we're talking axis 2, right? So, and this is what it means when all these SIRS explanations are explained away as neuropsychiatric symptoms. I think Dr. Greenblatt also alluded to this fact that we have all these precise DMS categories in which almost any somatic syndrome is going to fit. With anxiety, and you're going to see all the tremors, twitches, that buzzing, the insomnia, shortness of breath, chest tightness, diarrhea, dizziness is going to be called anxiety without batting an eyelash. If they're complaining of fatigue, hypersomnia, insomnia, pain, constipation, weight gain, reclusiveness, lack of focus, anger, that's all going to go somewhere under a mood disorder, usually depression. And this is what it means when a psychiatrist says, when a doctor says there's nothing here psychiatry can't cure. Now, this was actually written on one of my patients' charts by a neurologist. He happened to be a physician who went through his records at a later date when he got better. He wrote down everything that had been said about her. This one he found the most angering, that complaining of all of these things, the neurologist had simply written, nothing here psychiatry can't cure. Fairly insulting. So this slide is one of the more important, I'm going to say. Again, if you're a professional treating this, is differentiating inflammation, in my experience, induce sickness behavior from the psychiatric syndrome we call major depression. And sickness behavior is really well studied in animals. I like to explain it to lay people as this is what happens when your cat gets sick. You can't find it anywhere. You go looking all over for it. You find it in the back of a closet you had forgotten about. You try and tempt it with little treats, little toys, and mostly it's just sort of either does nothing or hisses at you. You can't tempt it. And at that point, when you see a cat like this, what do? You obviously take the cat to a vet, although I know some people would call a cat psychic. But the loss of pleasure, the reclusiveness, the fatigue, the loss of appetite, the lack of pleasure in usual things, in a person, we tend to call this depression. When induced, it's probably really more cytokine inflammatory induced sickness behavior, which has a real evolutionary advantage in the survival of the species. Now, the difference I've seen in patients who might really be more classically typified as major depression is the feelings of inappropriate guilt, worthlessness, complete hopelessness. When I hear that, there are people I might be saying, I think maybe we should consider stronger treatment or try some psych meds. It's very rare for me to hear feelings of guilt about, that are completely unrealistic, etc. So just a clue here. And just want to remind you, as you probably know, is that we do have a long list in psychiatry of infectious and neurotoxic pathogens. In fact, our first meds, as many of you know, were really for TB, which got repurposed for mood disorders. So we have biotoxins we're going to talk about. Neural Lyme, tick-borne infections, which is a whole nother topic, extremely common and looks a lot like Lyme. Streptococcus pans, causing the movement disorder, but now really implicated in childhood onset OCD and very common. And we also have a number of just Rocky Mountain spotted fever, toxoplasmosis, again, very well documented, and research in suicide and schizophrenia. So thinking about inflammation and infection is not a total, quack idea. There's an awful lot of basis for it already in psychiatry. It's just, we don't think about it much. So the Few studies there are that really directly correlate exposure to water damaged buildings with depression and cognitive dysfunction. This was a study done in 2007 in about 6,000 Europeans living in visible mold, found about a 40% increase in depression over residents in buildings without visible mold. And realize this is visible mold, which I almost never see in the US. That's pretty rare. So this has been well documented. It's a real study that mold is increased with a a significant association with depression. The complaint I hear with anxiety is just my brain does not work the way I used to. That's a most common complaint. There are several studies documenting that there is cognitive impairment, that it's quite real and reversible, with reduced cognitive functioning, poor short-term memory, slowed processing, and impaired executive functioning being the major findings. And you can see the list there, and there's actually a couple of more in the most recent bibliography at the end of this lecture. There's one more study, and it's possibly the most frightening to me. This was about 300 Polish children who were studied from birth, and at age 6, the children living in homes with visible mold were almost 10 points lower on their IQ standing. And there's almost a direct relationship between time of exposure and decline, with children who had spent 3 years at home having about a 5-point decline. We don't have follow-up on the status, but given how common mold is, and we're going to talk about that in the US, to think about that effect on developing brains is something to think about. In Arizona, we still use swamp coolers, which are basically large containers of warm water, which are open to the elements and pretty much just breed mold, and it's sprayed through some sort of duct system. And in the poorer communities, it's still used for cooling instead of AC. To my mind, the fact that Arizona usually comes in last or nearly last on most of the national testing we have, I think there is some association here between the use of swamps and cognitive impairment. My opinion, of course, please understand. The depression as an inflammatory illness there are a lot more studies, and there's far more extensive research. I gave you some of the names of the titles, and again, every year we see more and more. So the cytokines, just to go over that, they're immunoregulatory proteins. They're secreted primarily by the immune system, such as the macrophages and white blood cells. They carry signals from one cell to another, and they contribute greatly to the inflammatory response in SIRS. Here are 6. These are the most studied in the psychiatric studies. MMP9, which is metallomatrix proteinase, TGF-beta, transforming growth factor, are used all the time in diagnosing mold illness, and they're both inflammatory cytokines. They have a real role in increasing blood-brain barrier permeability, exciting glial excitotoxicity, and contributing to the imbalance of Th2 over Th1. Interleukin-6 is very well explored in psychiatric illness. We don't measure it as much in mold, I think, because it's slightly harder to measure using commercial labs. The next 3 slides show a number of studies and meta-analysis done. State of the art, at least this was 2016, 2017, it has the levels of evidence here, which are quite high. It's not hard to find elevated inflammatory cytokines in mood and anxiety disorders. And again, the most studied cytokine is interleukin-6 and C-reactive protein, technically not a cytokine, but it is stimulated by inflammatory cytokines in the liver. Here are 4 meta-analyses of depression research. All found elevated cytokines, especially interleukin-6, were associated with depression. And again, all the most recent references from 2019 and 2020 are at the end of this talk. Anxiety disorders, OCD, again, increases in pro-inflammatory cytokines and low. In some, they found cytokines reduced. OCD, by the way, is pretty commonly seen in children with mold. I see it as a contributor to PANS, as do many people, as contributing to the autoimmune encephalopathy we now associate with childhood onset OCD. Bipolar illness, absolutely associated with inflammation. Again, 3 meta-analyses to check, and you can see, again, major inflammation is present in all our major psychiatric illnesses. And in my experience, bipolar illness plus what we call brain on fire or mold inflammation, really difficult to control until the environmental inflammation is handled. Something to remember clinically when you have somebody you're just really not able to quiet down and stabilize. This is a nice study on microglial activation in bipolar patients, and microglia are the primary homeostatic guardian of the central nervous system. They have critical functions in both during development, neural circuit reshaping, and during adult life in the brain. And they have a dual role in growth of new neurons and neurodegeneration. Microglial activation is pretty much synonymous with neuroinflammation. One of my favorite slides to show microglial activation in the development of schizophrenia. And it's an excellent study, longitudinal study showing inflammation preceded the onset of neuropsychiatric disorder, in this case, schizophrenia. This was PET scans of healthy, high risk, and then schizophrenic patients showing an increasing gradient of microglial activation in their schizophrenic progression. I like to always point out there was a point there before they received the diagnosis of schizophrenia when they had microglial inflammation, which could have been treated. Now, we don't know the causes, but I think they're all the causes we've talked about prior, including mold. So I think, again, a real role in psychiatry for working with inflammation. Alzheimer's and inflammation is unfortunately the ultimate neurodegenerative disease anywhere, everyone's fear, I think, as they grow older, if there's any family history, very much associated with increased cytokines, including TGF-beta, which is also consistently elevated in mold. And Alzheimer's type 3, if you know the Bredesen protocol, is the least likely to have the APOE4 marker, seems the most related to mold toxicity. If you remember the case study I gave you at the beginning, my first mold patient really could have been considered the onset of dementia if someone else had been seeing her. And I've personally, over the years, seen at least 2 patients who were given the clinical diagnosis of Alzheimer's, were in the Alzheimer's clinic at U of A, reverse with Sears, and be kicked out of the Alzheimer's clinic without any explanation of like, well, you don't belong here anymore. I always wondered, well, who was telling them that? Didn't they wonder for one moment what could reverse Alzheimer's? Since as far as I know, Alzheimer's is not reversible. Bredesen protocol being different, but traditionally we don't think of being able to reverse Alzheimer's. And I think that differentiates those of us who are exploring these fields and those of us who are working in clinics saying, you have Alzheimer's, here are your drugs. Inflammation and suicide, the studies here are really good in terms of how highly linked inflammation is. And again, we've talked about how many patients have told me, you know, how situational or environmental their onset of suicidal ideation is. This is a place mindfulness treatment is helpful. If you can tell people, look, if you were feeling fine, walk into a building and start wanting to think about offing yourselves, just, you know, just regard these thoughts as clouds and just walk right out because they will dissipate and it's not real. And a lot of people get that pretty fast. Oh, it's not me. Whatever this thought is, it's not me. So again, persistence evidence points towards low-grade inflammation. I'm sure you've talked about quinolinic acid. It's produced in neuroinflammation through the degradation of tryptophan. It increases glutamate excitability, which again, known as excitotoxicity, and again, associated with every major mental illness. Here's the pathway I just described. And again, it's going to be clearly present with the presence of inflammation and the degradation of tryptophan. To me, this is one explanation of something I see very commonly. People will be given something to enhance their tryptophan, given tryptophan to help them sleep, to help their depression, and they go, they become more agitated, more suicidal, they feel worse. This is the pathway. It goes down, and that is an enormous clue, that paradoxical reaction, that you're looking at neuroinflammation, and you should be looking again higher upstream of what's causing this paradoxical reaction, instead of just looking, well, what's the next supplement? What's the next drug I should try? VEGF is very familiar to those of us in the mold community, is vascular endothelial growth factor. It's a really important player in the brain. Most of us know it as decreasing the flow of blood to the fingers, to the feet, to the extremities, but it really increases blood flow through increasing capillary growth, also to the brain, incredibly important. And so it does play a major role in neuroplasticity, neurogenesis, synaptogenesis. Really important and very decreased usually in mold and chronic fatigue. So this is one of the best studies I've ever seen on suicide. I think it's from Karolinski Institute, and I think Harvard was involved, is they studied people at high risk. They looked at the complete suicides, and the strongest finding they found was low levels of VEGF were associated with completed suicide. So just a thought why we measure VEGF. I try and measure it on everybody, and work with trying to improve it, although I don't have a one supplement way to improve it. It's difficult to fix. Okay, neurohormones and inflammation. We've just talked about dysregulation here of cytokines, but it dysregulates the immune system and the hormonal system, as well as the inflammatory components, and hormones are also really important here in mood regulation. The ability to handle stress is, as we all know, resiliency, but I love showing this slide because I think it just expresses it so well. I do show it to patients. I use it to them as they don't understand resiliency. And I think by mid-2021, many people are beginning to just slink away from that cat behind them. They've, had a difficult year. Low resiliency is pretty common now. This is the cortisol pathway, and again, plays a really important part in resiliency as well as neuroplasticity. And many people with SIRS are going to have adrenal dysregulation, which presumably is playing a role in their neuroinflammatory illness. It is not the major cause of everything you see. It's, again, more of a downstream effect. You're not going to get someone better just by treating adrenal dysregulation. However, it's a component of the treatment. And this is an interesting, very interesting hormone, vasopressin antidiuretic hormone. It's actually been really well studied in prairie voles, and that was Thomas Insel's research, the head of NIMH. And its kissing cousin, of course, is oxytocin. So prairie voles do mate for life, and nothing like that's ever been found in humans. But this blissful monogamy they have has been shown to be totally related to their high levels of both oxytocin and vasopressin. And it's upregulated epigenetically when the voles first mate. And again, while we haven't discovered that in human, we have unfortunately discovered the opposite, is that SIRS completely downregulates antidiuretic hormone. That frequent urination, which is so common, is always accompanied by that very low or non-existent antidiuretic hormone. So, and that's been measured in most mold patients, again, very low. And at some point, I began thinking, wow, all this kind of internal, there's a lot of interpersonal stress and difficulties in most relationships going through mold illness. And to suggest that a a molecule, a water retaining molecule, could affect behavior is profound, but it's true. And I think it does contribute to some of the mold irritability, which is seen. And again, sometimes I'll explain that to couples who are really having a difficult time, is maybe you could just all learn to wait as we treat the antidiuretic hormone. And I do use, by the way, a fair amount of oxytocin now at bedtime as a troche usually. And that has a similar effect in decreasing the frequent urination. And in some people, usually people who's had a history of trauma or women who are postmenopausal, it works really well in terms of not just the urination, but seeming to give an improvement in resiliency and mood. So we're now on diagnosing and treating mold, and this is an enormous subject. The first thing you need to know is mold is essentially a brand name, okay? So it's the brand name for more than 30 known contaminants that have been demonstrated in water damaged buildings. And it's really important to remember that there are multiple triggers for the inflammation we see in people living in sick buildings. This is a long list of all the documented pathogens, inflammagens, and toxogens found in water damaged buildings. And some are pretty surprising, like beta-glucans. I mean, that's used for immune modulation. It's positive. Actinomycetes and endotoxins seem especially important, according to Richard Shoemaker's later research. I routinely measure mycoplasma in my patients, and I'm surprised how many are positive for both IgM and IgG. So you can look through this whole long list, the fungal fragments, the VOCs, the bacteria, the gram-negatives, gram-positives, the viruses, and realize that calling it mold or measuring only mold in, say, a urinary mycotoxin test does not really measure in any way all the rest of these, which may be contributing to the inflammation we're seeing. And that's going to bring us into something you need to understand is 10 years later, I can be pretty succinct here, is there are two major schools of thought, and it's really important to understand this before you go and get certified or learn some treatment protocol. In one, it's believed the inhalation of mold spores, such as mycotoxins and other contaminants, all these fragments and VOCs, et cetera, is thought to cause primarily inflammation through activation of the innate or the older immune system. It's also known as the Shoemaker school. Another school believes the installation of ingesti of fungi and mold spores causes colonization. In other words, the mold spores and fungi are living and growing and excreting within the human body, contributing to the symptoms we see. So key point here, it's basically, as in many areas of life, the lack of good, easily replicable actual data of controlled studies, let alone randomized controlled studies, lets opinions play an outside role in treatment. And you need to just remember that is you're going to hear very strong opinions, but not so much actual data. And you can now see that really my most coveted role in helping co-create ICI was chairman of the research committee, where after being vice president and president, I now reside, since it really bothers me personally how little real data we have and how many people we're treating with testing, as opposed to the number of very strong opinions you will hear. So having made that point, because I'm sure a lot of questions are going to come up about which is right, neither is right by the terms of controlled data or level of evidence that we look for. And here is just my key points for psychiatrists, and we stop at the slide. We've fulfilled one of my own personal goals in teaching about the implications of inflammation and brain disease, is be aware environmental toxins play a role, and probably a major role, in causing neuroinflammation and neurodegeneration. And be aware that when you see people with multiple symptoms and multiple diseases and diagnoses, we've seen multiple doctors, given multiple treatments with little relief, it does not mean they're psychosomatic. It's such a common presentation in mold illness and Lyme too. In basically the group of patients I and many other doctors see every day, all day. Things I see in people who've been given a psychiatric diagnosis, who I re-diagnose, is an unusual age of onset, is, panic attacks at the age of 60. I mean, yes, it can happen, but we're going to usually see most major things like bipolar and stuff sitting in their teens or in early 20s. Makes me uncomfortable if I see diagnoses given at the age of 65. No family history. A person's bipolar diagnosis given at the age of 65 and no family history, and I have seen that, really stop and think. And this paradoxical reactions I just talked about is the small doses of something you give increasing anxiety through the roof. You give a little bit of Xanax and the person is, wanting to swing off the walls, feels suicidal, and you said, I don't know how that happens, is to think about inflammation. Not histrionics first, at least first thought. I want to go over the mechanisms again before I go on treatment, because I really do believe that understanding things sometimes is more important than learning a protocol that you can go out and use the next day. I think that's a more old-fashioned point of view, but I think it's useful. Is this slide summarizes again, we're looking at neurohormonal dysregulation, hypothalamic pituitary axis. We're looking at inflammatory cytokine upregulation, and we're actually looking at end organ and cellular damage. The brain damage from mycotoxins, the actual mechanisms are very real and well documented. I tend to gloss over this a little bit when I'm talking to lay people because it is frightening, is the neurocognitive deficits, the neuropathies, demyelination, the neuroinflammation and neurodegeneration, again, is well documented. Most of this is reversible. Some things like demyelination and neurodegeneration are going to be harder than neuroinflammation to reverse. The mechanisms of damage, again, to understand how you're going to treat this is definitely oxidative stress. All of this is documented, and I give all the references at the end of the lecture, is oxidative stress, depletion of dopamine in the striatum, okay, Parkinson's. How many people are you treating for dopamine deficiency? Have you thought about ochratoxins? OTA is ochratoxins. Alternation of cholinergic and dopaminergic transmission, mitochondrial dysfunction, that's trichothecenes, that's black mold. There's also trichothecenes can directly destroy neurons too. Mast cell activation and degranulation, very much attributed to mold and mycotoxins, leading to neuroinflammation. Penetration and destruction of the blood-brain barrier, causing damage to its integrity in the neuronal tissues. And mycotoxins can also bind at neuronal synapses to different sites, leading to decreased neuronal plasticity. Think, autism and Alzheimer's here. And again, literature supports all of this. So once you've suspected that mold is impacting some of the symptoms you're seeing, how do we actually establish the diagnosis? Again, two schools of thought here. And I think let me just describe both. Shoemaker approach is going to be measuring multiple labs, measuring cytokines and neurohormones. Shoemaker protocols, the pros are many, if not all, are covered by insurance. Shows the presence of neuroinflammation. It shows the Th2 imbalance. That's really important to understand, is why a person, is not responding to documented treatments, trying to kill things when their Th2 imbalance is really high. And the neurohormonal disturbances. The cons are these are not specific for mold, certainly related to Lyme, gut inflammation, allergies, autoimmunity, but they give a pretty good picture of that Th2 imbalance and other cytokine issues. Number two is urinary mycotoxin tests that show the presence of mycotoxins produced by various mold families. The pros is this is really easy to understand for the patient and the beginning clinician. You give a person a box, they send off some of their pee, we get a diagnosis. It seems much easier than it really is. The cons is many arguments here, one of which is there's much more than mold in a building. Two is you can't distinguish between food indigestion and environmental contamination. And you have no idea really whether when you see low numbers, when you're looking at someone who can poorly detoxify, or whether you're seeing someone who's actually healthy. My opinion, I like both. And I certainly insist you have to have a history, you have to have symptoms before you even start about testing. And unfortunately, what I see now is someone handed a box, they get a high number, and someone like me is called who said, like, well, do you have an illness? Is where we start, we go backwards. One thing I've slipped in here quickly, because it's really one of my favorites, is volumetric imaging is a tool that's been used by many, including myself, as a measure in the assessment of mold patients. And I think it's of significant interest to the psychiatrist. The volumetric imaging is an MRI of the brain that it's going to include a volumetric analysis of multiple gray and white matter regions. It takes a 2D segmented image and reconstructs their 3D volume. It's traditionally used to diagnose Alzheimer's through enlarged ventricles and a small hippocampus. Definitely can be used to assess TBI. And it can really show a lot about the functional architecture of the brain. These reports are available at many radiology facilities. There are two, NeuroReader and NeuroQuant. NeuroQuant has the advantage of being FDA approved, covered by many insurances, including Medicare, and available all over the country. So it's the one that I've used the most. And this is for reference to keep if you're going to order it because you're intrigued. These are the orders. I ordered these reports, especially the triage brain atrophy, general morphometry, age-related, and I'll often order the lesion quant, which is very useful for MS. Diagnostic codes I use are just all the neuro symptoms, you know, TBIs, neuropathies, dizziness, migraines. And again, cash-based here in Arizona and Southern California, a NeuroQuant MRI plus the software is going to be costing in the winter here like $350, $300 in the summer. That's actually about the cost of getting a urinary mycotoxin test. So this is just to intrigue your analysis. It's a triage brain atrophy report of about 50 regions of the brain, which to psychiatrists, first time I saw one, it was like, whoa, the amygdala, whoa, the hippocampus, whoa, we can see white matter here inflamed. It was the thalamus. It was very intriguing. You can certainly look at the limbic system. This is a NeuroQuant patient, a NeuroQuant pattern. And again, I'm going to go over this very quickly. This is not teaching. This is just to pique your interest. You can see in her extreme neuroinflammation, those are the blue, and these are age and sex match controls. So for her age, you know, female and sex and age, you're seeing extreme neuroinflammation or microvascular edema. You don't really know which. In the cerebellar and cerebral white matter, extreme enlargement of the limbic centers, including the thalamus, hippocampus, amygdala at 99th percentile, and you're seeing prefrontal and middle frontal atrophy. Okay, I think we know in psychiatry, this is going to mean someone with poor executive function and control of an overactive limbic system. And in fact, in mold patients, that dysregulated limbic system is probably the most common psychiatric observation you can make. It's not a diagnosis. It's more an observation and can be confirmed usually by the NeuroQuant. So, and I think this person had severe suicidal ideation, ketamine. I think she was hospitalized and transcranial, and actually none of it really worked until we got her out of mold and worked for a while with other treatments, including binders. So just an introduction, but I am working on a course with documenting how to use this for psychiatrists, ICI. If you join ICI, which I highly encourage if you want to learn more about this, we have several courses we've done in videos, myself and a neurologist who uses it a lot too. So there's a lot more places there to start to learn how to use this. Treatment strategies in my last 5 minutes. Primary importance, there's no doctor, no matter what their beliefs are about inhalation versus inflammation, who's going to say it's okay to live in mold. You have to get people out of mold, and this is usually the hardest part of treatment. There are 2 ways to do it. You can move into a new home, or you can remediate your current home. Pros and cons here, but I will say overall, my experience has been that only about 1/3 of the people I've treated who pursue remediation actually end up with a home that they can continue to get better in. So, and that's pretty similar for many people who've been treating for a long time. So that's, you know, probably about 10 hours worth of information in one slide. You need to remove the toxins, and that's going to be using a binder. 2 types, the bile sequestrants, well called cholestyramine. They are stronger, they bind to the bile, they prevent enterohepatic recirculation, and they pull out the bile with the toxins. And that allows, the theory is, the cell membranes and organs to release more toxins into the bloodstream. You can use the natural binders, which bind directly to the mycotoxins. Clay and charcoal are the most common. Very large database of efficacy in animals that this works. And the natural binders are much easier to tolerate, but again, are going to be a little weaker and slower. As you're removing binders, you can work with detoxification, and people who tolerate it, glutathione or N-acetylcysteine are most commonly used. I like to really encourage bile or phase 2 push-pull, using either TUDCA or a combination of phosphatidylcholine, taurine, and glycine. It gives good results. Bitters is a really nice way to encourage the flow of bile, as does eating some fatty foods. The sensitive patients is a whole nother realm. This has been where I've probably ended up. My niche is teaching, treating mast cell patients and sensitive patients. And it's probably at this point 3/4 of my population who have problems with one of the first 2 or 3 of these steps, who are the ones down to eating 5 foods, reacting to everything. No treatment you come near with them makes them better. And usually what's involved is a combination of mold infections and something called mast cells, or what used to be known a little bit more as histamine intolerance. These are the simplest points to remove. To remember, if you're starting to treat people, the bowels have to move. The bowels don't move, you are not going to be able to use binders. And there are multiple strategies here, of which the simplest are things like prunes and fiber or calm magnesium citrate. The sweating is something that works in infrared sauna. Again, slow but helpful, and people often can tolerate a pace of an infrared sauna. Lymphatic drainage, what I call manual techniques, sometimes colonics, again, done by certified body workers, therapists, and that can also begin to encourage the body to detoxify without using any sort of supplements. And this is going to be a place where many people have to start. So this is, again, an extremely short course in what, again, can be a very long lecture. This is simply neuroinflammation is the major condition I see on neuroquants. The symptoms is the microglial activation. I think you can assume when you're looking at a mold patient, you're looking at a lot of neuroinflammation. You want to use good fats, so fish oil, olive oil, which I really like these days, is a tablespoon of just drinking extra virgin organic. Olive oil really seems to help vagal tone. It's very anti-infective. And it can be tolerated when people are feeling they're having histamine issues with fish oil. diet. You're going to hear multiple suggestions of what mold diets are. I'm really happy if people just will do a low carb, usually autoimmune paleo with some intermittent fasting. I think we talked a little bit briefly about this before I started, is that many patients descend into the depths of self-treatment with mold diets, histamine diets, and oxalate diets, into eating pretty much lettuce and bok choy when I see them. I think in the 90s, I would have been calling them anorexics. We don't use that. I don't think it is anorexia, but I don't like to encourage more food restrictions than I have to. But the low carb is really anti-inflammatory and tends to help. Phosphatidylcholine, and that's my philosophy. Phosphatidylcholine is really useful with calmag butyrate, helps the myelin sheaths. Curcumin, of course, is well documented for depression and anxiety in the brain. Resveratrol can help lower MMP9. Tocotrienols, again, TBIs and neuroinflammation. Selenium, and I have a nice reference there. And organic lithium, which is can be very useful in patients with having mood instability. And in fact, because dehydration is so common with the low antidiuretic hormone and living in the Southwest, I will encourage people to use coconut water and mineral waters, Gerald Steiner and Pellegrino, which have fairly high levels of organic lithium. And actually, that's well tolerated. I don't think, I've had very few people say they can't do that. And you see some usefulness after a couple of weeks that it's helping hydration and I think mood. And hydration, by the way, is very linked to mood in a number of studies. Restoration of the biome. Just know that we can have all sorts of colonization, bacteria, viruses, and fungi in the nose. The nose is very closely related to the brain. A major interest of mine is what that triggers in the brain. I've tried many, many things to get rid of everything, and Xlear, commonly available, is my current favorite because of the availability. It's also anti-COVID in test tubes. It's well tolerated, and it works with hydration of the nose. And GI, here are some suggestions that seem to work the best when you're starting to try and restore the GI microbiome. You're going to see gray matter neurodegeneration with the inflammation. VIP is a peptide I don't have time to talk about today, but is very much used in mold treatment. Exercise, incredibly well documented. You can't really get much aerobic exercise with people with chronic fatigue, but you can get them moving, and that helps. I always like pointing out all the antidepressants, including ECT, have been documented to increase gray matter. I try and be fair. I don't quite understand it, but it's true. Meditation, of course, diet, and curcumin, zinc, and taurine, and lithium too, has been documented to improve gray matter. So this is the biography I've promised, and it is very updated and excellent if you wanted to start reading about it. And I am going to just make a plug again for, if you want to join a professional society for learning to treat with, I think we now have 500 members. We started with 3 in 2017. I think this speaks to how profound the need is for training, education, and research. Please go to the ICI website, apply as a member, and I think we'll get your answers to many of the questions, which are probably waiting for me here, there in fuller detail. So, and this is a picture of Tucson. Actually, it's the view from my front hacienda. I'm looking at it now. And today we've actually had beautiful 3 days. It's looking something like that. So we don't get to see it, full year, but this is me, and I'm finished, and I'm very open to taking some questions now.
Great. Okay. Thanks, Dr. Ackerley. We will start with some questions. The first one, could you speak about your experience with the specifics to reverse tinnitus as it relates to mold exposure in the brain? They said that they see a lot of clients, and sometimes it resolves when we detox, but sometimes it does not.
Yep, that would be my experience. And I wish I knew. I think viruses are the most accepted accepted etiology, pathology. However, the vagal nerve attaches to the cochlea, and I think the eustachian tube even. And I believe that, again, improving vagal balance, which is a really important part of treating limbic dysregulation, also helps the tinnitus, and it's kind of neglected. I even have eustachian tube exercises that I think work better than the usual vagal treatments. So all the treating the inflammation. And again, my experience is exactly that, is you do everything you know, and lots of times it gets better. People get less annoyed by it, might be the better way of saying it. They're just less sensitive and focused on it.
Okay. Other than genetics and exposure, what other factors predispose a person to SIRS onset? Possibly nutritional deficiencies, low vitamin D, etc.
First of all, I just want to correct the genetics, is that the widely publicized genetics, 25% of the population, the Rosetta Stone, has never, ever even been published, let alone reach the level of the randomized controlled trial. So it is purely a clinical observation. The last time anything was, done with it and looking at patients was 2003. So we're more than almost 20 years past those statements with no further diagnosis or anything that supports it. So most doctors, including myself, when we finally figured this out, stopped, calling people dreaded or giving them some sort of prognosis based on their HLA. We all assume genetics are involved. They have to be. But the idea that there's one easy one for mold and Lyme has never received any sort of published verification. So correcting that misconception, or even 25% of the population, my experience is 100% of people, if exposed to high enough levels, and I've seen some really, really bad cases in my history, will have symptoms. There's no one immune from it. It just is a dosage and time effect. What do I see? Most of the people I see are women. So I think women are affected a little more quickly, and it's usually at the times of hormonal dysregulation. So we're already dysregulating hormones, and then at the onset of menses, childbirth, and really at perimenopause, menopause, when I see the bulk of the women enter my practice, that's usually the last straw of trying to cope with all the symptoms that they've usually been coping with for years. So hormones are really important. The presence of other infections, is having things like Lyme and Epstein-Barr, are just weaken the body. Those are really more my observations. And then there's luck. There's simply luck that you didn't live in that moldy house. You lived in the clean student dorm. Okay, you grew up in the cleaner home. So there's clearly a pre-existing. If you're asking me what genes predispose, I think it's all going to be in the mast cell. One's DAO mast cell inability to generate a lot of antioxidants to reactive oxygen species in the brain. So I think, to me, that is an area of interest to me, but there's no generalized, sort of like you don't looking at like an HLA archetype and then looking at a urinary mycotoxin and pronouncing, have mold and dreaded gene, is like, no, nothing there really to make that kind of a pronouncement to anybody. So I'm pretty straightforward about saying that.
Yep.
Sorry, it is, yeah. And most people are really, really relieved to hear, because if you have been told you have something dreaded at the genetic level, like at the level of having 2 Alzheimer's genes, at the level of having BRCA genes, you've been told with authority, you have something so dreaded, we're calling it dreaded, and your chances of recovery are really low. It is very hard to get that out of even your subconscious, even if you're the most positive, epigenetically minded person in the world, which most people with mold are not. It is really hard to shake that kind of a pronouncement. So I really am very firm about saying there is no level of evidence to say that to any patient.
Okay. I know you spoke quite a bit about the NeuroQuant. What is your favorite test in general to use for mold?
My ears, I'm serious, is you listen to, and you really actually, I have pretty extensive symptom checklists, and I take a history, because it's very rare that a person is well and then 2 months later, they're really sick. It does happen once in a while, but you take a history of exposure to water damaged buildings and you put that together with the development of symptoms that are not being explained. To me, the seeing 10 or more doctors and getting nowhere, and I've seen people see 50, 53 doctors, is really like a clue to be looking for mold. My favorite testing is, I will go always for the inflammatory tests. I've been doing them since 2010. And I have a tremendous amount of faith in being able to look at them along with the history and see the symptom severity and the hormones. I do use urinary mycotoxin testing. I'm currently running a research project that's pretty interesting of comparing these. I think any of us who do a lot of these know that they very rarely add up, even on urine sent from this same, one person sending the same urine to different places do not look the same. So it's hard for me to have much faith, but I use them, believe me, when people I know they have mold and they don't want to listen. I'm very happy to show them that level of proof. There's mold in your urine. And that tends to convince people. So I will use them as an object of persuasion. So again, I'm coming more from a shoemaker school, but I have not, I don't trust their validity at the level I would like to.
Okay. Where do you get oxytocin? How do you dose it? And do you measure ADH first?
I measure ADH in people with good insurance. Medicare doesn't pay for it. The levels of times it's been more than, say, 1.8. Like I can almost remember those patients. It is so commonly less than 0.8 that, and because insurance doesn't always pay, I tend to just measure osmolality here, which is a really important measure to me because dehydration is so important. I do, again, just ask, how many times are you getting up to urinate? And then I think, oh, duh. Or I'm looking at my, list of, I'm going to start with low dose naltrexone. Didn't mention it there, but I use it all the time. And think, this person does have some trauma, is getting up at light. I need to get them to sleep. I'll use oxytocin. The side effects are very few. I mean, person may just, not sleep well for some reason on it. That would be it. Or it doesn't do much. I usually go with 50 IUs, but I do have a few people who just really like it and take 50 IUs twice a day. If someone's small and sensitive, I'm going to start at like 30. But I've just found over the last 2 or 3 years is that 50 is really well tolerated as a troche. Hopkinton will make it, mixtures, my local pharmacy makes it. Most pharmacies will make it as a troche if they have to get the oxytocin. And it's more cost effective than using it intranasally, which some people do.
Okay. Can you speak to fertility or pregnancy issues with mold?
Yeah, that's the big unspoken. Is if you look at the animal literature, mold and the inflammation, if you just look at things like TGF beta in animals and stuff and fertility, it's not good. I don't think there's any reason to think, women with mold are doing a real favor to the fetuses. I think miscarriages are what I've seen increased. In terms of decreasing fertility, I don't know. I wish I could show you, though, a picture of one of my patients who we call it the melatonin miracle. Is I'm, very happy about it, is someone who'd been in a fertility clinic for 2 years with all of these diagnoses, mold, EDS, POTS, mast cell, the whole bit, who I said, everyone get your melatonin up. It's really great for neuroinflammation. It's helpful for the inflammasome. This was the one thing she could tolerate. She got hers up to 60 milligrams. She got pregnant the next month after 2 years. And the kid was born about 2 months ago. Beautiful, beautiful baby. She wasn't living in mold at that point. Other issues had been there. So melatonin at least does increase fertility. Not known to me and not known to most doctors. I will tell you that that is a side effect of melatonin, a wanted side effect for most. But I would say that I could never say, I don't, if a woman's pregnant, living in mold is the best they're doing, I'm not going to tell them. The animal literature is doesn't speak too highly of this. It's like, hey, let's, do the best we can in treating this, etc.
Okay.
Probably does decrease fertility.
Okay. For patients with persistent fatigue, can intravenous therapies like poly-MVA or PC be helpful?
I refer people, well, 3 questions there. For persistent fatigue, if I knew one miracle, I would be sending everyone to do it. It is the hardest and the longest acting symptom of mold. And I do think it is the cell danger response that has to be addressed, that there's no one therapy. But given that, one of the things you can do, I like NAD maybe the best. I use a lot of phosphatidylcholine, and I refer to a couple of clinics that do the IVs. For people who can afford it, I think it's one of the best helps. And I've seen people grow gray matter with phosphatidylcholine. It helps neuroinflammation and it helps detoxification. I don't use that much poly-MVA. I know it does help mitochondrial issues. And I have had a couple of people use it who say they really feel great with it. So it's kind of like the alpha lipoic, I think, that's had some stuff done to it. So again, I don't have a miracle, or again, I'd be using it all the time.
Right. Okay. Are you recommending in your protocol using XClear for MARCONs? And what is your opinion regarding treating MARCONs?
As you probably gathered, I do have an opinion. I usually do. I've been treating it since like 2010. And I've done a long slide series. I didn't show any here today, in which I knew it was becoming increasingly difficult to get rid of. It used to be I treated MARCONs. I got rid of it fine. In 2013, I inherited a large number of patients who'd been told they've been cleared of MARCONs because the person releasing them had just tested once, treated them for 30 days and never retested, just said, oh, you're fine. Well, most of them weren't. But we treated, I was still on retest, was getting rid of it. 2014, it was harder. We just saw this. By 2017, I did a really nice story of showing how BEG increased very clearly microbial resistance, where we started out with like 6 resistant, we went to 8 resistant, then 10 resistant, I think 13 resistant. As I continued to try and use BEG to get rid of a husband and wife of, their MARCONs. And I think at that point, I completely stopped using BEG because I figured it was doing harm. I documented it's doing harm. And my level of enthusiasm for treating MARCONs after that is low. I will usually try it once, maybe twice, of using something like EDTA silver. And I've tried many, many herbals, and I don't have any shooting success story. I'm trying the latest one. Hopkinton is advertising. I don't have enough to report. My level of enthusiasm is very high for using XClear and for using nasal rinses. Is just teaching people to clean their noses twice a day. Using either or both seems to actually have a lot of helpfulness with allergies, sinuses, and feeling better with all of it. When I retest, have not necessarily cleared the MARCONs. Again, what I'm trying to say is over the years, I think with increasing microbial resistance in patients, or maybe seeing many sicker patients, I have less and less and less success with clearing it. And I see many people get well without clearing it.
Okay. Do you see a connection between SIRS, mycotoxins, and low cortisol?
All the time. Yeah, I thought I said that is you always are seeing what's called adrenal fatigue. Sometimes you see the opposite, the very high cortisols, but usually I see low cortisols, the low resilience, and it's part of the fatigue. Yeah, it through multiple, probably damage to the HPA axis is a major cause.
Okay. Do you ever use cannabis to support your treatments that you're doing?
All the time. CBD. CBD is incredibly useful for neuroinflammation. And I mean, there's a lot of research on that. I don't use THC very much. I've seen too many, like most psychiatrists, people get psychotic on it for me to really feel enthused about it. But CBD, I use an awful lot. And I don't prescribe very many controlled substances anymore, and I won't start people on Klonopin or Xanax without them trying CBD consistently, and usually I'm successful with that.
Okay. Is it common for SIRS patients to also have invasive fungal infection? And what is your preferred treatment for that?
That's what I was trying to say is that's the second school of thought, of which I was trained mostly in the first. You can document using micro-DX that people do have fungal infections. Now, for a long time, I was taught that I was killing people if I used antifungals. And if you retested, if you did the fungal with just doing EDTA silver, you would often see the fungal go. So it is antifungal, and I think I've been treating it too. It's very hard to know that you actually have a fungal infection, except through culturing it out, and everyone will tell you it's very hard to culture out. I have used some of the other antifungals, which have not been that well tolerated, but I'm fine with using herbs and silver. But I've begun to have more reservations about silver as a heavy metal and getting into the brain. And again, that's just as you go on, you begin to wonder, you know, there's silver now, and they just had a study, silver was found in dolphins. Okay, they did a study on bottlenose dolphins, and evidently silver goes nowhere, so it's urinated out, finds its way into the oceans. And they did studies on bottlenose dolphins, finding that they had a much higher Th2 imbalance, higher Th2 associated with these silver microparticles in the macrophages. And I'm like, well, I am trying to get Th2 down in most of my patients, and I'm using silver. How is that helping? And there are some studies it gets in the brain. So just telling you, I don't think there's a perfect, nor are the people I've seen forever on, say, amphotericin, ketoconazole, or whatever is being used. They're on it so long, I'm not sure that, you know, how we know they've gotten rid of it. I do like ENTs scraping things. That seems to work better than any nasal spray I've ever tried. Is having the actual surgical intervention is, I think they do a better job, because people just are not consistent using whatever spray you give them, not for 3 times a day for 2 months, whether it's antifungal, antimicrobial, or anti-whatever. So I think, you know, ENTs can get it out and people will see relief.
Okay. And any experience with ozone from Archons?
Yeah, again, you're going to think, is that our dentist here uses it, you know, she's a ozone trained and very good, uses it a lot. I've seen 2 cases of loss of smell. And we know that that certainly happens through the olfactory nerve with ozone. One came back pretty fast within weeks. One took like 3 to 4 months, I think, to resolve. And it was just with ozone treatment for Marcons. So I haven't seen it get rid of Marcons, but again, I can't give you anything that, you know, definitively, except maybe ENT scraping. And I think there's a risk with ozone getting through these very permeable blood-brain barriers. It doesn't belong in the brain, and it does seem to do damage to nerves. So someone told me recently they can use it in ears. They use a little stethoscope and they use like a nasal or an ear insufflation with it. You know, and they say that that really helps with sinuses. I haven't tried that, but I don't see an objection to that.
Okay. And can you speak to any remedies for helping correct vision from mold exposure?
I mean, the first is the removal from mode. You know, the small protocol I gave is going to help a lot of people with the blurred vision, the red eyes. Normal treatments for dry eyes. I use a lot of ketotifen because it's anti-mast. So if those simple things aren't working and a person's out, I'm a very big proponent of vision therapy at this point, because we have someone very good in Tucson who can do all the right measurements and treatments, show people that their visual maps don't map up with their auditory maps, and use prism lenses. And I find some real improvements with that. So goes from kind of simple to more complex visual therapy.
Okay. Do you treat with biodynamic hormones for menopausal symptoms in combination with mold treatment? And how do you parse those out? Or is it even necessary?
Oh, it's totally necessary. I'm a strong proponent of using them. And it's just hormones and estrogen are really critical for the brain, for the female brain. I personally believe the studies are really good on its effects on the loss of estrogen and the loss of brain matter. I personally don't do as much anymore because of malpractice issues covering it. And I do have a number of people I refer to who I feel are more qualified at this point to take the risk. Because even if you want to argue there isn't a risk with cancer, which people will do, and I actually tend to agree with it, as a physician treating it, you have a heavy malpractice standard of care community against the use of estrogen for women after menopause. So beware of that. I use a ton of progesterone, which I don't feel is associated with cancer in anybody's mind. Natural prometrium, it's the first thing I use when someone is having problems with anxiety, not sleeping, and is at menopause. And it works really well. So I think it's a vital part of treatment is hormones, including the adrenals, including replacing all of them, pregnenolone, the DHEA. I haven't gone into all those aspects, but yeah, you're trying to get the body to give it as much things as it needs to start to get back on a normal regulation of its hormones.
Absolutely. Okay, and one more question. Someone was wondering what the difference is between AAEM as an association and ICI.
ICI is treated more specifically for the environmental interactions, but it's treating more specifically with mold, with Lyme, with metal toxicity. So it is similar, but it is nonprofit education, and we're open to more than MDs. So it has been considered, there is also, I think we're considered to have the least amount of bias. There's nobody, we're teaching multiple methods of all of these and trying to really encourage research in a different way. We're hoping to not have bias, but to simply begin to encourage the education of people and research without running into all the pitfalls that have been before with fungal versus antifungal versus inflammation.
Okay, great. Well, thank you so much, Dr. Ackerley. This was a fantastic, very valuable presentation.
You're welcome. You're welcome. Yes, okay.
And everyone, this has of course been recorded and it will be added to our website, hopefully in a few days on the webinar library page. It will be available free for 30 days. And then once you access it there, you'll have 90 days of access to it. Thanks so much again, Dr. Ackerley.
You're welcome. Thank you for having me.